All right, welcome back. It's time to learn about Chapter 23, Nursing Care of the Newborn and Family. A lot of what is covered in this chapter, I feel like I've kind of gone over in the previous chapter with the newborn adaptations to life. So I'm going to go pretty fast through this chapter, okay? Buckle up. So the baby has been born. What is the RN supposed to do now? Well, um, the RN needs to do a very rapid assessment. The things that you're assessing are listed for you on your slide. However, I didn't put this on your slide, so I want to make sure I really stress and emphasize it to you guys now. Always wear gloves when handling a baby that has not been bathed. Whether it's the baby's born vaginally, whether the baby is born by C-section, always put some gloves on. Unless you're willing to stick your hand up the mom's vagina ungloved, then you should wear gloves when handling her baby, because that's where the baby just came out of. That's called using standard precautions. The overall primary goal in the first few minutes is to assist the baby with the transition and to establish respirations. Hopefully, the baby is of term gestation and will come out with good muscle tone, crying, and routine care can begin. If everything is going well, the baby will be placed prone on mom's chest and the nurse will begin rubbing the baby down, partially to stimulate respirations and partially to dry the baby and prevent hypothermia and cold stress. It's important to cover the mom and the baby with a warm blanket. If the baby is apneic or gasping, they're going to need ambu bagging. If the baby isn't breathing, um, or if they are gasping, giving them blow-by oxygen is not going to help. You can hold blow-by 100% O2 underneath the baby's nose all day long, and if they're not breathing, it's not going to help. It's not going to make one darn bit of difference. So if somebody's not breathing, you're going to have to breathe for them, i.e., ambu bag them. It is better to bag a baby on room air if that's all you have access to. In fact, most neonatal resuscitation says to start bagging at room air at 21% O2. And then if you're not getting significant improvement, then you can start, adding in some blended O2. But in an emergency situation, bag that baby on room air and get oxygen moving, get them breathing. Then usually they will pick up their respirations and start on their own. But they may need a little bit of a jump start to get going. Again, I told you all this during the last chapter, but one really cool trick to obtaining a newborn heart rate is just to palpate the base of the cord. Sometimes the delivery room is really noisy. Mom's talking, dad's talking, grandparents are sometimes in there, friends are in there, everybody's talking, everybody, wants to take pictures. You've got equipment and tables that's being moved around. You've got monitors that are shrieking. Bed alarms can be going off. Doctors are talking. Nurses are talking. If the room is too noisy for you to auscultate and listen to a heart rate, then you can grab the base of the cord and you can palpate that base of the cord. Try and, you palpate for 6 seconds and then take that number and multiply it by 10 to get a heart rate. You can do the same thing when you are auscultating too. You can just listen for 6 seconds and then, multiply by 10. You don't want to do that all the time, but when you're just trying to get like a 1-minute APGAR, you don't have a lot of time to, it's a very rapid assessment. You don't have a lot of time to wait a full minute. So if the baby is doing okay, then the baby is going to be weighed, measured, dried, and then they'll take footprints and place ID bands and security bands to the baby, and the baby gets to stay in the room with mama. Please do not waste time memorizing the APGAR table. Unless you are going to be a labor and delivery nurse or a baby nurse, you do not need to memorize an APGAR table. And even then, you will memorize it just because you will use it so often if you end up attending a lot of deliveries. But I do want you guys to know this. An APGAR score of 0 to 3 is really bad. Scores of 4 to 6 indicate distress, and scores of 7 to 10 indicate that the baby is having minimal difficulty. In general, newborns get an APGAR of 8 at 1 minute, 9 at 5 minutes, or 7 at 1 minute and 8 at 5 minutes. Occasionally we see a baby get 9 at 1 minute and 10 at 5 minutes, or sometimes they'll get this exact same APGAR like 9 and 9 or 8 and 8 or something like that. However, you want your 5-minute APGAR score had better be higher than the 1-minute APGAR score. Babies should be breathing, their heart rate should be greater than 100, and their trunk and lips should be pinking up. If your 5-minute APGAR goes down rather than going up, then you're in some serious doo-doo, and you better be calling the NICU for some assistance. This slide just goes over the newborn hospitalization overview. It just kind of goes over the steps. The baby is born, goes here, does this. You can just kind of read through this on your own. We say that the baby gets the PKU test drawn. We kind of, I think I did change it on your slide. It says newborn screening / Billy check. What they check for is they do check for PKU, for the phenylketonuria. But they also check for cystic fibrosis, galactosemia, congenital adrenal hyperplasia, hypothyroidism, maple syrup urine disease, sickle cell. There's a whole host of like rare, inherited, oftentimes metabolic diseases that the hospital will check for and screen for. And then if the baby goes to the NICU, they can do an expanded screen to check for even more things. And they just do it all with a simple little heel stick. Okay, so you are going to admit a baby to the mother-baby floor / nursery. What information do you need from the L&D nurse and report? Well, you need to know you need a lot of information about the baby. APGARs, was there meconium? How has the transition been going so far? You want to know the delivery details. Was it a spontaneous vag delivery? Was it vacuum assisted? Was there forceps used? Was it a precipitous delivery? What drugs was mom given during labor? When did her water break? When did the baby what exactly was the time? So you can decide how long was the water broken between when the baby was actually born. Does mom have group B strep? Has mom had a positive drug screen during her pregnancy? Has there been any problems with the pregnancy? How has the bonding been going so far? You need to verify that the vitamin K shot was given and that the erythromycin eye goop was given also. There's a lot of things you need to ask. Then the mom and baby are going to arrive to the floor and you're going to begin assessment of mom and baby. Some of the things you need to ask the parents about: do they have a name for this baby? Do they smoke? If they smoke, then you should offer smoking cessation classes, and you need to let them know that they have a child now. It's not safe to smoke around the baby, and if they're going to smoke, the baby has to stay on the floor, and then somebody has to stay with the baby while their parents go downstairs to smoke later. If it's a boy, you need to ask if they want to have a circumcision done. You need to find out if they have a car seat. Is it installed? Do they need information about installation? You also want to find out if there's a family history of milk intolerance. If this is mom's 4th baby and she comes in and says, oh my gosh, all of my babies end up on soy, lacto-free milk, and I do not want to breastfeed. Are you going to start this baby on regular infant milk? No, you're not, because odds are if the other 3 kids were lactose intolerant, this baby's probably going to be lactose intolerant. Save everybody the heartache and hassle and just put a call into the pediatrician and say, there's a family history of milk intolerance. All of her other babies have been on this. She wants to feed her baby this. Is this okay? 9 times out of 10, the pediatrician will say yes. Once the mom gets to the floor, again, you do the assessment of the mom and baby. You'll get mom put to bed and you'll do a rapid visual assessment of the baby. Then you'll have to do a complete assessment of mom and baby. Again, in this chapter, we're focusing on the assessment of the newborn. So I want you to consider the baby's airway, vitals, their head to toe assessment, birth measurements, and focus on keeping the baby warm. So newborn assessment actually starts with the maternal history. So again, we want to know the maternal prenatal care. We want to know mom's medical and social history, birthing history, delivery details, anesthesia, pain control. These are all the details of her labor and delivery. Times that the baby will be assessed. Well, in the delivery room for APGARs right after birth, at 5 minutes, and then every 30 minutes thereafter. Upon admission to the floor or the nursery. And then once the baby kind of gets settled down, Then the baby will just, switch to probably Q shift, every 6 to 8 hours be assessed. And then again, babies have to have a assessment before they are discharged. APGARs, any birth complications, how long the water was ruptured, was there a nuchal cord, meds the mother received in labor, any known or expected anomalies, any recent infections in the mother, mom's blood type, this is a big one because this affects baby, the results of her prenatal labs, such as her hepatitis B, HIV, her RPR level, her rubella level, all those things. Past pregnancy history, any substance abuse, and did the mom receive any tocolytics during pregnancy too, because something like terbutaline can cause the baby to have low blood sugars. Stadol makes babies very different after they're born. It definitely affects them. There's a great box 23-1 on page 583 in your book that I would highly encourage you to review. If the baby has a temperature at delivery, then they may have to be sent to the NICU for evaluation for acute chorio or sepsis. Tip: before you unwrap a baby and make them fussy, because in general, when you unwrap babies, that makes them fussy, check the resting respirations first. Whenever I do assessments in babies, it's different. I do it in a completely different order than I would if I was doing it for adults. I always check even before I touch them. Just as I approach the crib and see them laying there, then before I even touch them, I will check their resting respirs first. And I usually count them for a full minute because babies tend to breathe irregularly. They also breathe very shallow and they're deep. And then sometimes they just pause breathing. As long as they're not apneic, that's just called periodic breathing. So that's normal. Normal range for breathing is 30 to 60 times a minute. After I check their breathing, then I check their heart rate. Their heart rate should be between 120 to 160. Here's another tip. Take the stethoscope and warm it up in your hand before you put it on their chest. Because can you imagine how much your heart rate would increase if you were all cozy and warm and then somebody put an ice cube on your chest? You would jump and your heart rate would skyrocket. Babies are the same way. So warm it up before you stick it on them. And then they usually won't cry too much. When babies are asleep, obviously their heart rate goes down. Then I will usually unwrap a leg if I have to do a blood pressure and check their blood pressure next, because they generally don't really like the squeezing of their leg. The very last thing I do when I'm taking care of a baby and assessing them is I always check their temperature last. And this is because they hate it. Honestly, I will tell you, they tolerate a rectal temperature better than they tolerate an axillary temperature. For some crazy weird reason, if you take a thermometer and stick it in the middle of their armpit and hold their little arm down, they will scream and they cry like you are pulling off their toenails. But if you stick it and do a rectal temperature, they just lay there and look at you like, okay, is this it? It makes no sense to me, but that's just how it goes. So, if you take an axillary temperature first, it's going to increase their blood pressure, increase their heart rate, increase their resting respirators. It throws off and skews all of their other vitals. So save the temperature for very last. All right, so I know I just talked a little bit about temperature on the last slide, so I'll let you kind of read through the rest of this. This just kind of gives you some temperature ranges back and forth. One of the best things you can do for a baby is crank up the temp in the delivery room so that baby is toasty warm when mom delivers. And then keep the baby skin to skin with the mom. If that baby gets cold, you are in a mess. Babies can die from getting too cold. So remember that if you are ever assisting with a delivery in the ER or in the grocery store parking lot, keep that baby warm at all costs. So here's a little bit of cocktail trivia or history of this new Ballard tool. It's actually a simplified version of something that already existed. Somebody named Dubowitz came up with a gestational age assessment first, but His was kind of complicated and too difficult to complete sometimes, especially with NICU babies that didn't fit. So somebody named Ballard came up with another tool that was much easier to do and also worked with the NICU population. So the observable characteristics of the newborn need to be evaluated before you disturb the baby. That's an ongoing theme. Observable things should be evaluated while not disturbing the baby to get a true assessment, a true accurate assessment. You're looking at the skin. Is there, for the presence of vernix caseosa, is there generalized peeling? Any birthmarks? Is there milia? Is there bruising, petechiae, head molding? Is the skin thick or thin? Is it transparent? You're looking at, is there lanugo present? Is it plentiful or sparse? We talked last chapter about sole creases. The earlier the baby is, the less sole creases they have. That means their heels are slick. Breast tissue, the closer the term a baby gets, the more breast tissue is present. Ears, again, I think we talked about this. If babies are less than 34 weeks, the ears don't have cartilage, so when you fold the ear down, it just stays folded down. By 36 weeks, there is some cartilage present, so when you fold the ear down, the pinna will spring back slowly when folded. But by term, the pinna has pretty good cartilage in it, and it stands away from the head, so when you fold the pinna down, then it springs back quickly. And genitalia, I went over that in a lot of detail in the last chapter, so I think you guys are good there. So look at these 3 different babies and look at what the differences are in their resting postures. Postures in babies of a full-term baby needs to be flexed at rest. Notice how floppy the first baby on the left is. There's no tight flexion, no tone. The baby's arms are just splayed out, legs are nearly straight. This baby is premature. The second baby has a little bit of tone. See how the legs are kind of frog-legged up, but the upper extremities are still not flexed? This baby is premature also, but closer to term. And the third baby is term with excellent tone and flexion. See how the arms are flexed and the legs are both flexed? That is exactly perfect baby tone. Then after you do the observable things, then it's time to assess the neuromuscular assessment of the baby. And I listed the little tests that we do for that on your slide. But these are the ways that, these are just more ways for nurses to help determine the gestational age of the newborn. All right, so the first test is the square window sign. To do this, you just gently flex the baby's hand down until resistance is felt. Now in the first baby, this is a premature baby. See how the angle is only about 90 degrees. I'm talking about the first picture that's on the left. Then we look at the picture that's in the middle. This picture, this baby is probably, the angle is about 30 to 40 degrees. So this is about 38 to 40 week gestation baby. And then the third picture, wow, I know a lot of you guys are getting squeamish and want to vomit at this, but I promise you are not hurting the baby. This is a beyond term gestation baby. See how they can flex their hand completely flat back against their forearm? I promise you that baby is not screaming and crying at all. This does not actually hurt them, but it does kind of make your toes curl when you look at it. To check for the popliteal angle, place the baby flat on their back. Then you flex the thigh up to the abdomen, and then while holding their thigh flexed to the abdomen, then you extend the lower leg and measure the angle. Full-term kids don't have hardly any resistance to this, but preemie babies do. To check for arm recoil, first before you check the arm recoil, first it's easier to check the baby's legs, honestly, because development starts in the lower extremities first and then works its way upwards. So you place the baby flat on their back, flex the baby's legs for a few seconds, and then flex them up like they're supposed to be up towards the belly, and then you extend them down flat, and then you let go. Term babies will recoil their legs and pull them back up. Preemie babies have less muscle, and so they may not do this. And then to test the arms, you're going to do a similar thing. You'll flex the arms at the elbow, flex them up so that the baby's hands are, up near their face for about 5 seconds, kind of charge them. And then you extend their arms flat and let go. The arms should fly back up at that angle that's less than 90 degrees if they are term. This works best if the baby is greater than 1 hour of age. All right, so to check for heel to ear, you place the baby flat, then you pull the ankle upward until resistance is felt. Then you let them bend their knee. Preemies can place their heel to their ear or beyond. Full-term kids cannot do this. The scarf sign is kind of fun too. All you do is you place the baby supine, again, we do this a lot, and you pull their arm across their chest until resistance is felt. And then note the position of the elbow in relation to the midline of the chest. See how the first baby on the left pulls their arm all the way over? The elbow is moved easily beyond the midline. That's a preemie baby. The second baby in the middle, when you pull their arm across, their elbow lands pretty much at the midline. So this tells you that this is a term baby. The third baby, the elbow doesn't reach the midline at all. So the elbow really only reaches, like the rib cage. So that means that this baby is beyond 40 weeks. All right, so then the other part of this is to weigh and measure the baby. It's important to plot their weight and gestational age on the growth chart. Of course, you're going to measure the baby's length, head, and their head circumference. And then, of course, babies get complete daily weights too. So what are the things that influence birth weight? Well, a baby's race, the mother's diet, if the mother smoked, the size of the parents, the interval between the pregnancies. Those are all things that affect a baby's birth weight. Some hospitals will also want you to measure the chest circumference and abdominal girth as well. Okay, so we can also classify babies by their weight. AGA means that the baby is appropriate for gestational age, that their birth weight lands between that 10th and 90th percentile. Then we have large for gestational age babies. That means that these babies grew at an accelerated rate during pregnancy. That means that in general they weigh more than 8 pounds and 14 ounces or more than 4,000 grams. And that when you plot their gestational age and their birth weight on the growth chart, they fall, in that greater than 90th percentile. Small for gestational age means that their birth weight is less than the 10th percentile. These babies grew at a restricted rate during fetal life. Small for gestational age babies are common in moms who smoke or have hypertension. These babies are also more likely to have polycythemia and hypoglycemia too. SGA and IUGR stands for intrauterine growth restriction, are often interrelated, but they can occur independently as well. In general, an SGA baby is simply small, while a baby experiencing IUGR has suffered some sort of compromise, including maternal infection, cord issues, placental insufficiency, or other anomalies. We'll talk more about that in the NICU chapter. You can have a large for gestational age preterm baby. I've seen it. I've taken care of them. Babies that are, large for what you would expect a 28-weeker to be. You can also have a small for gestational age term baby, where you have a full-term baby that comes out at 41 weeks and they are still small. They're still like 5 pounds and 10 ounces. The size does not always correspond to the overall maturity of the baby. We can also classify babies by their gestational age. Preterm babies, which means that they're born before 37 weeks. Then we have late preterm babies that are born between 34 to 36 weeks. Late pretermers account for 71% of preterm births in the U.S. Late pretermers often have respiratory distress, temperature instability, hypoglycemia, apnea, feeding difficulties, and hyperbilirubinemia. They're jaundiced and they're going to need phototherapy. Then we also have our term babies who are born between 37 to 42 weeks. Then we have this new term, it's called early term. These are these babies who are born at 37 to 38 weeks. This is kind of a new category. So what they found is that compared to full-term babies, early-term babies are at greater risk for short-term and long-term health problems, such as breastfeeding difficulties, respiratory distress syndrome or RDS, TTN, that transient tachypnea of the newborn. They're also at higher risk of ADHD. They also have higher neonatal, postnatal, and infant mortality rates. And then, of course, we have post-mature babies who are born after 42 weeks and showing signs of placental insufficiency. And this concludes part 4 of your newborn and NICU unit.